Hello, everyone. Welcome to the final CardioLAN of December 2017. We thank you for joining us, whether you're participating in the live event or whether you're watching the archive recording. We really appreciate your participation. With us on the line today from HHQI is Misty Dyke, our communications specialist. We have Misty Kevich, our RN project coordinator. And for those of you I have yet to meet, my name is Cindy Sun, and I'm also an RN project coordinator here at HHQI. Today is the day. It is our favorite topic of the year. This is when we hear from those who are doing the work and making the quality improvement changes to their practices. Today we have 4 agencies represented agreeing to share their strategies, their processes, so hopefully we can all learn from each other and then maybe even adapt some of their successes into your own agency. Now before we pass it over to them, we have a few housekeeping items as well as a few announcements we want to share. All the lines are currently muted. We encourage you to use the chat and the Q&A feature on the right-hand side of your screen. If you're not seeing those features currently, please click on the icons in the upper right-hand corner to activate those features that you're missing. And when you're sending your comments and questions, if it's possible, send them to all participants. We'll get to as many Q&As as we can today. And for those of you that are listening and not part of the active webinar, if you'd like to send in questions, please submit those to hhqi@qualityinsights.org, and we'll address your questions as well. Now, a few announcements. First, blood pressure guidelines. Most of you are probably already aware of it, but we wanted to make sure to let you know that the American Medical Association and the American Heart Association recently released updated blood pressure treatment guidelines. And these guidelines will be reflected in the updated HHQI Cardiovascular Part 1 BPIP, which will be released towards the end of January. This is the BPIP that was originally released in 2013, and because of the guideline changes, has gone through many revisions. This will be yet another revision, and we hope to have it out there for you guys by the end of January. The HHDDR, the Home Health Cardiovascular Data Registry measures, those are adopted or adapted, if you will, from the National Quality Forum, NQF, and CMS's Quality Payment Program, or QPP. We'll only adapt the current HHQI BP measures when and if either of those national groups make adjustments. We'll keep you posted on that. Now, speaking of HHDDR changes, I'd like to take a minute to provide you with a few of the details with the upcoming changes to the HHDDR. First, most importantly, the cholesterol measure. As I just mentioned, we at HHQI, we don't make alterations to these measures unless the original overseers of the measures make changes. The current HHQI cholesterol measure is no longer supported, and it's going to be removed from the HHCDR, or the term is sunsetted. So we're sunsetting that measure from the HHCDR. For this reason, starting with your January 2018 discharges, the new cholesterol measure will be measure 438, which is statin therapy for the prevention and treatment of cardiovascular disease. This measure is going to be able to provide you a rate of patients considered at high risk for cardiovascular events who were prescribed or taking a statin during the episode of care. The second change to the HHCDR will be the addition of a new measure titled Measure 643, Cardiac Rehabilitation Patient Referral from the Home Health Setting. And this measure will provide you a rate of those patients who qualify to receive the referral and did receive it during the episode of care. Patient population in this measure will include patients who have experienced an acute myocardial infarction, chronic stable angina, undergone coronary artery bypass, a CABG, a PCI, percutaneous coronary intervention, cardiac valve surgery, CVS, or cardiac transplantation. Now, all of these changes will begin with your January 2018 discharges, and they'll be seen in the HHCDR on March 15th. And if you have specific questions or you'd like to discuss this further, feel free to contact us at hhqi@qualityinsights.org, and that address is also on the final slide. We'll be glad to talk to you about it and give you any insights that we have on it. The support materials will be posted hopefully towards the middle to end of January regarding all of this, but we have no problems and would love to talk to you about it ahead of time if you care to discuss. One last announcement about the HHDDR, and this is a very special thank you to those of you who have provided input through the annual survey. It's the survey that you see when you first open the registry that comes open once a year. The time on that 2017 survey will be taken down in the next few weeks. So if you've been wanting to provide feedback but just haven't taken the time since it's been posted, your time is limited. We just wanted to let you know and thank all of you that have provided the feedback. Okay, to save the dates, and we'll get into what we're doing today. Save the date, January 18th. Should say save the date, please. From 2 to 3 p.m., 2 to 3:30 p.m. Eastern, the Underserved Population Learning Action Network event is titled Actions to Improve Health Literacy. This presentation is going to discuss health literacy barriers and strategies for various areas, including measurement, navigation, verbal, written communication, and evaluation. In other words, if part of your practice is to touch a patient education tool, you probably need to have this information. That's why I wanted to share this with you, because most of what we're doing in the cardiac work these days is with patient education. So wanted to let you know about that content coming up. And the second save the date I'd like to mention is February 27th. Yes, it's a very long way away, but I wanted to make sure that it was on your calendar if you're interested. From 2 to 3:30 p.m. Eastern is our annual broadcast webinar celebrating Heart Month. This is something we do every year, and this year the title is Cardiac Rehab Roundtable. During this roundtable discussion, leading national experts will discuss cardiac rehab, the impact it has on hospitalization rates, and what we in the home health world can do to increase the referrals when the patient is healthy enough to leave our care in the home. All right, let's get in with today. I think everybody seems pretty settled in now. The objectives. When you leave here today, we have high expectations for you. We really hope that you're going to be able to describe how data will drive your quality improvement efforts, list some ideas for motivating clinical staff to focus on the basic tasks and perfect those, such as proper technique for blood pressure assessment. We hope you'll be able to apply next steps when blood pressure rates are not at the national standard or where you want them, and maybe provide ideas to improve care for patients with both depression and cardiovascular disorders. And finally, we hope that you'll be able to describe the impact the Million Hearts ABCS has on hospitalization rates. Our presenters today, I'm going to go ahead and introduce all four of them, and then we'll turn it over to them. We're going to start with Mary Thiessen. Mary is the quality analyst for CARLE Home Health Services of Urbana, Illinois, which is part of the CARLE Foundation Hospital. Mary has over 8 years of experience in the healthcare industry, first as a mental health case manager in Missouri and Minnesota, and then as a managed care case manager for Medicaid patients in Illinois. Mary has a bachelor's degree in psychology for the University of Dayton. Next, we have Eric Wilson. Eric is a BSN prepared registered nurse with a Master's of Science in Nursing, Business and Health Systems from the University of Michigan with specialty focus of patient safety outcomes and health systems. He holds credentialing as a certified professional in healthcare quality through the National Association of Healthcare Quality Nursing Executive Advanced Board Certification by the ANCC, and wound care through the National Alliance of Wound Care and Ostomy. Eric's clinical experience expands a variety of areas, including emergency services, home health, wound care, and behavioral health. He has contributed to quality improvement initiatives not only within his organization in the SEMI, but nationally with NAHQ as a contributor for the competencies for healthcare quality professionals, population health, and care transition, and is a core leader in the behavioral health special interest group. He has experience as a nurse planner with the State of Michigan Home Care and Hospice Association. He is currently engaged in the educational and quality improvement endeavors that focus on access to care, barriers, and solutions in the care transitions for complex patients, value-based transitional care, patient self-management, mental health screening, and implementation of evidence into practice. Eric is dedicated to the population health movement and improving care not only to complex patients, but also in the preventative care in decreasing the incidence of complex patients in the population. Our next presenter is Vanessa Massey. Vanessa has been an RN for 37 years, with 29 of those years in the home health industry. She has done clinical practice in the field for both home care and hospice, has been the education coordinator and quality manager. In her current position, her focus is on quality and process improvement, compliance, infection control, safety, and education. And our final presenter today is Nancy Schroeder. Nancy is an RN BSN for the past 5 years. Nancy has been the clinical program specialist for Visiting Nurse Association of Kansas City, Missouri. To improve transitions of care from hospital to home, Nancy currently meets with the patients prior to hospital discharge who have elected to go home with home health care. Nancy oversees the program development of advanced illness management, that is COPD, heart failure, diabetes, CABG, and MI. Nancy designed and implemented teaching manuals to help patients understand and identify personal goals in managing the disease process and to improve overall outcomes. This past September, Nancy spoke at the National Quality Outcomes and OASIS C2 Conference in Improving Patient Outcomes in the Cardiovascular Milestone 5. Nursing specialties have included 22 years in critical care, 12 years in cardiac rehab, 6 years as the director of telemetry unit, and 5 years in home health. I'm sure that you can see we have a very impressive panel with us today. And with that, I will turn this over to Mary Thiessen.
Good afternoon. As Cindy said, my name is Mary Thiessen, and I'm the quality analyst for CARLE Home Health Services and CARLE Medical Supply. And I'd like to thank Cindy, Misty, and the team at Quality Insights for inviting me to share what quality initiatives are working for CARLE Home Health and where we're headed in the future. We are located in Champaign-Urbana, Illinois. If you've never heard of either of those towns, they're both home to the flagship campus of the University of Illinois. So go Illini, at least in basketball. Football is another story. Some information on CARLE Home Care. We've been Medicare certified since 1983, providing services to East Central Illinois for over 30 years. We are a unit of the CARLE Foundation Hospital, which is a not-for-profit private agency. And we provide skilled nursing, physical, occupational, and speech therapy, home health aid services, and medical social services. In addition to home care, we also provide hospice services. We also work very closely with our system's durable medical provider, CARLE Medical Supply. We've been doing quality initiatives for some time as part of the requirements for accreditation, and our accreditation specialist is also working on the quality initiatives. But I've been on board for the past year as a full-time quality analyst, and with the changing conditions of participation, our leadership felt the time was right to devote one person exclusively to quality. In the past year, our major initiatives have been on our 5-star rating and several pieces which factor into the 5-star rating. Currently, we're at 3 stars on Home Health Compare for quality of care and 4 stars for patient satisfaction. Improvements over the past year have paid off for us in a big way, and at the next refresh, we will see an increase in our rating to 3.5 stars. Our next goal is 4 stars, and we want to go all the way to 5 stars and sustain this rating. We've been doing this by focusing on our process measures and procedures related to timely initiation of care, ensuring that our nurses and therapists are doing their drug education, and we are also renewing efforts to push flu vaccinations, giving clinicians some tools and training to engage with patients about the benefits of flu vaccinations and dispelling some myths about the flu vaccine. Though the flu vaccine will soon no longer be part of the 5-star rating, we still feel this is a good initiative to continue with new COP requirements relating to infection control. As we know, influenza can be devastating to persons with serious heart conditions. A large part of our 5-star initiatives has been to reduce our rehospitalization rate. We're almost always below 15% for an individual month, and that's okay, but it could be lower. And especially with the potential for changing payment models and penalty diagnoses related to cardiovascular health, we felt this was essential to work on. To begin with, we are using a similar tool to the zone tools available from HHQI. We have started small. We're only using the one for heart failure patients right now, but this has yielded some amazing results. In 3 months, we've gone from the 16th percentile to the 30th percentile to the 50th percentile in the amount of heart failure rehospitalizations among people who use our software, with higher percentiles being fewer hospitalizations. And we can't wait to see where the next months take us. In addition, we took the main idea behind the Call Me First poster available from HHQI and we created a magnet for patients to place somewhere convenient for them in their home, presumably their refrigerator. If they're not feeling well, we hope this will prompt them to call our 24/7 triage line for advice. Of course, if a symptom appears immediately life-threatening, we advise calling 911. The zone tools for CHF and for other conditions and for the Call Me First poster are available in the HHQI Fundamentals of Reducing Hospitalization BPIP, or Best Practice Intervention Package. Focusing on cardiovascular health, what has worked for us? The largest impact has been communication and collaboration with physicians. Now, given that our agency belongs to a hospital system, this is probably a bit easier for us than an independent agency. I still think this can be done with an independent agency, communicating the goals, especially focusing on the ABCS data with physicians from whom you receive the most referrals. I also have to give a shout out to our outstanding social work team as well. They have been especially helpful in helping acquire blood pressure monitors, unaffordable medications, and smoking cessation resources for our patients. With smoking cessation, they've also been very helpful in supporting patients who are trying to quit smoking and referring to mental health treatment if additional support is needed. Your social workers are an extremely important resource, so please do not be afraid to use them. If you do not have social work on your staff, it may be worthwhile to see if this can be contracted or if you can even hire one. We have also asked our clinicians to be on the lookout for issues related to blood pressure, aspirin use, cholesterol levels, and efforts to reduce smoking cessation as a regular part of their job duties, and to discuss with the patient's physician if an issue should arise. We also participate in the HHCDR for comparison with other agencies. We are able to see where we are above average, average, and where we need some improvement. So what are the next steps for us in quality initiatives? The first thing we are doing is submitting our data for achievement of Cardio Milestone 4, Assessment of Data Reliability, for the HHCDR. This data is currently being reviewed. Once this milestone is achieved, we will begin working toward Milestone 5, which is sustained improvement in an area deemed reliable in Milestone 4 for 3 months in a row. I suggest reading up on those requirements so you know exactly what's required and can plan for the submission of data if this is something your agency wants to do. Another area that our clinicians will be trained on is motivational interviewing. This is quite important in my work as a case manager, and I believe it's invaluable to persons trying to make changes for a healthier heart. So much of cardiovascular health is based on lifestyle choices. I firmly believe that nurses, therapists, social workers, etc., can sometimes get into the mindset of having all the answers when maybe there's other social and financial factors that are not being addressed, which present barriers for the patient. Or the patient could be completely overwhelmed by where to start. I like motivational interviewing because it is a goal chosen by the patient, and they are the ones taking control of their own care plan. HHQI has some great resources on motivational interviewing training, and I would encourage you to review them. We also have some additional statistics available to us that we could make better use of, and we want to incorporate these. Our software program for home care gives us personalized predictions for moderate and high rehospitalization risks based on answers to the OASIS items. We want to create a workflow in which the clinicians can focus on individual factors that the program is picking up and address strategies to reduce these issues that the factors can create. We would also like to analyze how many patients have an associated diagnosis with blood pressure, cholesterol, or any cardiovascular condition in which aspirin is a standard treatment, and compare that with how many patients are actually taking medications for these conditions. Finally, we'd like to create a resource center for our clinicians. The Resource Center would include information to distribute to patients regarding common symptoms, treatments, self-treatment at home, and when to contact their home health clinician, their physician, or, if necessary, 911. In addition, we are setting out to create care maps for our clinicians for common diagnoses and diagnoses which can affect cardiovascular health, such as depression and other mental health conditions. This will assist our clinicians in having confidence in treating the whole person, and especially if they're less familiar with one condition than another. And it will help our agency to give uniform care for any given condition, so that patients who come to CARLE Home Care know they're getting consistent evidence-based care, no matter which nurse or therapist they work with. Thank you so much for your time and attention to my presentation. I hope you have some great ideas about where to start or continue in cardiovascular health improvement. My email is mary.thiessen@carle.com, and I am happy to answer any questions via email and at the end of the presentation. Cindy, I think that's it.
That sounds wonderful. Thank you so much for sharing that. I think there were so many tips that you provided that no one could leave here without at least a few tips of things we could put into play. So next we're going to hear from Eric. Eric, I'll turn it over to you.
Thank you, Cindy. I am just waiting to be able to advance my slide. There we go. So today, thank you to the HHQI for inviting Optimal Care to come talk about how we use the quality or the CardioLAN in our own data. And I'm excited to present today on Optimal Care. We are a nurse-owned, nurse-operated home health care outside of the Metro Detroit area in Michigan. And we approximately service about 2,500 admissions per year. But I think one of our specialty things here at Optimal Care is that we practice from an advanced practice care model. And really what that means is we utilize advanced practice nurses, nurse practitioners, or clinical nurse specialists in the development of our care plans, evidence-based approaches in treating the complex needs of our patients here in Southeast Michigan. We are a 3.5-star quality agency and a 4-star patient satisfaction. We do fall into a very specialty area niche as we have a large behavioral health population. And so as part of the care that we provide, really integrating the mental health competencies and the behavioral health training with all of our clinicians, not just nursing staff, but all of our clinicians to be able to comprehensively care for all patients from a holistic standpoint, from an integrated standpoint. And really what that means when you have a diabetic patient who's also schizophrenic, and to be able to treat them in the community under one practice domain is really special to what home health care can provide. And under that advanced practice model, so programming these care models is really advancing the education of our staff. And that's making sure that they're trained and ready to treat these patients with complex conditions and comorbid conditions in the field. So whether that's the wound care certification, heart failure certification, psychiatric nurse certification, or dementia, getting them ready, getting them with the evidence-based measures to provide adequate care. And last but most certainly not least is the implementation of healthcare technology. So using the web-based EHR, but not just the EHR, making sure that our clinical teams are staffed and equipped with the tools that they need. So what we use are iPads in the field so that we can always be in communication with the clinicians if they have questions or concerns or need some type of telephone or virtual consult going forward, but also using the health information technology in our quality data programs. So the previous speaker spoke about the EHR being able to assess hospitalization risk, and that's a really special and quality program with built into your EHR. So really looking into those things, but also having the statistical knowledge to look at your data and analyze it. Who translates your data and what does it look like to your team? And that team includes your patients. So what does your patients look like as well? And how we try to do that. I'm just having a little trouble advancing the slides, I'm sorry. There we go. And so we really go from a data-driven approach to transform our outcomes, and I've just added a few examples of how we look at continuous monitoring, how we take Six Sigma principles and look at our run charts and continuous trending. And this is going to be really important as we move forward into the QAPI era for home health. Where do you really have to target your home health interventions? not only just looking at your adverse event data, but your OASIS data as well, to see where you're not hitting benchmarks. And when you start to transform that data, you'll really start to see improvements in your outcomes and process measures, because you know exactly what you need to target and how. For us going forward, we always implement from a small test of change first. So that, for example, could just be surveying our nurses or our physical therapists to see if what we're reaching for is even possible. And the other approach is a 1 to 5 approach, which is pretty prevalent in the IHI community of, taking one clinician and 5 patients to see if this intervention will really work. Last but not least, setting benchmarks. And setting benchmarks, we have to remember, not only improves the health of our patients, but it also improves the health of the population, and that's really what we're aiming for on a state, local, national perspective, is really improving the health of our population together. And as we look at state and national benchmarks, it drives us to work harder to meet the outcomes of those patients. Last but not least, our evidence-based approach to intervention planning. So whether it's agency-based or if we use the more advanced skill of formulating our own synthesis, but taking the systematic reviews, the clinical practice guidelines, which the HHQI or the CDC or whatever evidence-based reviews are out there, and putting that into your practice. Using those tests that have already been performed and tailor-making them to what you need to do. As well as also considering what we're doing here today, contributing to the greater growth of the health outcomes. So data sharing, collaboration, conferences, and what I really want to talk about is how we've taken the cardiac registry and really transformed our data from that. We felt that the cardiac registry was very important to our specific population, and it definitely meets the needs of the QAPI, because as we do this collective data gathering, we look at our top diagnosis and we see that it's mental health and circulatory. And from a national perspective, the circulatory falls in there, so we know a lot of cardiac conditions. So we knew we had to target this patient population, but we had to do a specialized target because we knew of the background of the coexisting conditions with these patients. So just a little small detail of what we look like. So from a national to an optimal cares perspective, our depression evaluation indicator for patients approaches 35% compared to a national, which is just approaching about 7%. So as you can see, we have a pretty high depression evaluation at start of care, resumption of care. And what are we doing with that? So first, this is just a small data aggregation of how we looked at depression and the treatment of those patients. And we looked just specifically on antidepressants. We know that there are other combination treatments that can be used, such as antipsychotics in the elderly or clinical non-pharmacological interventions. We really want to target those patients because we know the evidence is strong associated with the increased risk of cardiovascular disease, whether it's new onset or exacerbation in depression. For example, patients with myocardial infarction who also have depression have a higher risk of mortality than those without depression. So really targeting ineffective treatment and no treatment. Those patients are technically getting missed. What are we missing with those patients? Is it the appropriate discipline? Is it that clinical interventions aren't working and we need to look at depression treatment, pharmacologically speaking? So really working with our advanced practice staff, where we have 6 psychiatric nurse practitioners on staff, and starting to formulate advanced care planning with those physicians. And maybe it's a heart failure patient, which we also have family and acute care on staff. So formulating those comprehensive plans, saying, okay, what's our approach to this patient's cardiac condition as well as their depression? So taking that data and really driving outcomes from it. And so as we move forward and looking at the data, how we use the registry, we look at our evidence-based planning. Specifically, we've gone to the Johns Hopkins to see what they're doing from a cardiac depression, so an all-provider approach, holistic approach, how we initiate the PHQ-2 and advanced, when positive, advanced to PHQ-9, but also reassessing those findings. So once we start treatment, OASIS recertification or OASIS discharge doesn't really require you to retest patients and, have I made a difference? Have I improved the overall outcome? And then act on positive findings, which I already talked about a little bit. So consult providers for the treatment, initiate those evidence-based depression plans, and that can be done at any clinician level, whether they're the psychiatric certified or they're a medical nurse who's going in. They are trained from a standpoint of being able to treat the whole patient from those specific needs. And we really follow Dr. Naylor out of the University of Pennsylvania, who really advocates for advanced practice nursing in the home for advanced care planning and counseling plans. Last is just continuing to monitor. So we talked about the 1 in 5, but how do we keep going? So plan, do, study, tweaking, setting our goals, setting up time frame as well so that you stay on track. Root cause analysis look like from a depression and cardiac standpoint. The New England Journal of Medicine, the Catalyst article recently came out saying, should all hospitalizations be root cause analysis? I mean, really, should they be happening? What toll does that take on a patient to have multiple hospitalizations? We're really looking at your defined population. Last but not least, is just to continue to contribute to the registry. So extract our members and assess the needs. Any questions, feel free to email me, call me. I'm more than happy to talk. Thank you very much, and I'm going to pass it back to you, Cindy.
Thanks, Eric. And I want to thank you also not only for the great content, but those of us who are in home health and all of us in the virtual world, we know how it is to be fighting weather and connectivity issues. And Eric is a true champion, true home healther, and has fought outages all day today and was still able to make it today. And I'm sure everybody can now understand why we so much wanted you on today. Thank you for sharing that with us. All right, next we're going to turn to... I'm sorry, what was that?
I said thank you for having me, and I'm glad I made it.
Oh, we are too. So next we're going to pass the ball over to Vanessa Massey and hear her strategies. Vanessa?
Thank you, Cindy. I need to, let me advance my slides here. Thank you for having me today to be able to share our story. I've looked forward to it since our phone conversation, so I hope it'll be helpful to everyone. I first want to tell you a little bit about our company. We're located in East Tennessee in Knoxville, and we're a not-for-profit home care and hospice agency. We serve 17 counties, and our average daily census is around 450 patients. I included our pledge here mainly because our first initiative is our patients first, and I just feel like it goes hand in glove with the Million Hearts Project, so it's been very positive for us. So our journey with Million Hearts started back in 2015 in April, and we started out with the aspirin measure. We did that and added the blood pressure measure within 6 months. We progressed into the smoking cessation, and most recently, we have added the cholesterol measure. Working through the milestones, as many of you all are doing, the first one, of course, is just joining the project, and then milestone number 2 is downloading the best practice intervention package, and then also completing our registration, and then closing out our first month for milestone number 3. Milestone number 4 kind of intimidated me a little bit. I don't know if many of you are to that point or maybe even beyond, but I didn't know how comprehensive and how time-consuming that step would be. But I can tell you it's worth every minute to do it, and it's not overwhelming. So if you're just on the fence trying to decide, do I need to progress on, please do, please do. We got that accomplished on March the 8th of this year, and we were 1 out of 7 providers in the nation to achieve milestone number 4. So that just gave us fuel to our fire. So now we have accomplished milestone number 5. We reached that in October, and it was based on our aspirin as appropriate and blood pressure control for sustainability for 3 months in a row. We were the first in Tennessee, so we were very appreciative for that, and 3rd in the country to achieve milestone number 5. Some barriers that we've encountered in the project, which you all may have too, is that one was how our smoking history question was asked in OASIS. Because on our risk factors on MO 1036, it asked about current and past, So I had a little difficulty obtaining when the staff would check that, are they relating it to present or has it been a history? So we've done a lot of education on that, and that's helped me, especially with data collection. Hesitancy from the staff to address smoking and provide instructions, that's been a little bit of a barrier with just a few of the staff, but talking one-on-one with them and trying to explain the best practice to them and the benefit to the patient. If the patient can see it, if we can look through the patient's eyes and get them to be able to see the benefit of what we're trying to teach them, that's a win-win. Another barrier that we've had is our access to our cholesterol lab. So I'm kind of tickled to hear Cindy give that update. Our computer system that's integrated with our hospital doesn't always have that data in it. A lot of times it's done at the MD offices. And then calling the MD offices and trying to get them to share that information or to send it back, you know, that's been a barrier for trying to obtain the results. The video resources that HHQI provides for us, I can look at, but I wish our road staff had that capability. I now have learned through Cindy how to be able to help them be able to access. Our firewall was preventing that for a long time. And then lastly, the process to identify those patients needing the cholesterol management early in the plan of care, not just when it shows up on our report to be able to go back and review. We want to be proactive and capture it while we have them still as patients, foremost, to try to make an impact in what they're doing with their daily life. Some improvements that we implemented, we created a smoke and cessation patient education tool. We have utilized the Healthy Heart booklet for patient education. It's been wonderful as a tool. The staff education that we've done with current smoking as well as blood pressure control has been a benefit. The best practice handouts we've used time and time again for our communication board. And we are now, we were already in the process of getting a new route to obtain data even from the doctor's offices. So that's kind of stretched us a little bit to be able to obtain that. So that's been a good thing. And as well as focusing on our results, making it a priority and sharing it with leadership. Benefits from doing the project, I think the patients, number one, have been more empowered to be able to self-manage and prevent complications. The tools have been excellent. That's in the HHQI library. As I said, it's been great for our communication board, for patient handouts. We've seen a big benefit this year because we've had surveyors. We've also had some consultant visits, and they really look at this project as being very credible for quality improvement. So they've been very engaged and interested in what we're doing. We've received excellent support from HHQI and the QSource staff. The webinars and the training modules are easily accessible, and they're always current with the current healthcare arena. The reporting has been excellent, and as well as recognizing our own office or our own company within our healthcare organization for the advancements that we have made, as well as beyond for best practices. So that's always nice, and always encouraging the clinical staff out in the field to hear that good job being promoted and being bragged on. And then we've also been able to be linked to the Community Coalition, and I've really enjoyed that. I've only got to go for 2 meetings this year as we identified who my contact person was, but if you have access to a Community Coalition, I'd highly recommend it. You'll learn a lot from your peers. And that's all that I have. I thank you for your time, and I'll pass this back to Cindy.
Thanks, Vanessa. That was really great. I just want to, for those of you that are out there and want to clarify something on regards to when Vanessa mentioned QSource, she's talking about her ClinQIO. So if you're not already working with your ClinQIO, that is an extra resource for you that is available to help and support and guide you through this and with anything that they can do to help you. If you don't know who that person is, contact me and I'll be glad to get you in touch with them. There's never any obligation with anything that any of us do, but I want you to know, I was glad to hear you mention that, Vanessa, because the ClinQIOs are very supportive and helping the agencies in any way that they can. All right, so next we're going to turn this over to Nancy. And Nancy, the floor is yours.
Can you guys hear me?
Sure can.
Okay. I am having trouble advancing the slides.
Not a problem. If you want to just go ahead and we'll take care of that for you.
Okay, perfect. Thank you. Well, like the others before me, thank you guys for allowing me the opportunity to talk to you all today about how we accomplished Milestone 5 back in 2014, 2015. And just a brief, next slide if you would. Yeah, just a brief snapshot of the VNA of Kansas City. We are 126 years young, founded in 1891. Our agency covers 17 counties on both sides of the Kansas and Missouri state line, and we are in 211 zip codes. Our average daily census is about 640 patients. We do have 4 medical teams, and we have several specialty teams that include IV, mental health, wound care. We have developed some specialty programs to help with the bundling programs. Our strong foundations is our knee and hip replacement patients. And then our AIM program encompasses the rest of our team besides nursing, PT, and OT, but our dietitian, social worker, respiratory therapist, our pharmacy program, and our telehealth program. Okay, next. So when we were looking to help improve our rehospitalization rates, we looked at some ideas in the marketplace as to how we could do this, getting ourselves aligned in our competitive market and keeping us a proactive and an innovative agency. Okay, next. We started looking at some strategies that we could, that would help us kind of present, get us into a good place in our marketplace. VNA felt that we had all the right players. We just needed a way to pull everyone together. We had implemented our AIM program, which is Advanced Illness Management, just a few months earlier, and we were starting to see some good results, but we wanted more. So we were looking for a program that would maybe help hold us accountable so that we could push ourselves over that line. And we looked to who were our stockholders in all of this process. Next. So I had been doing, with all of my projects that I had been involved in, I was familiar with the HHQI and really liked what they represented, their goals to help improve the quality of home care, the networking opportunities that they offer, and then I was a big fan of their evidence-based tools and resources and utilizing their best practice packages to put together some of our teaching tools. Next slide, please. So it just made sense for us when I saw the Milestone project that this was going to be a good fit for us. It was a program that helped give us the accountability that we were looking for, and it provided us a roadmap to help achieve and provide those measurable improvements that we were looking for to help improve our rehospitalization rates. So when we started looking at which route to go with the best practice interventions, we, as with Vanessa, and kudos to you, Vanessa, for taking on all 4 of them, we were just brave enough to take on one, and that was our blood pressure control. So that was our primary focus on our start to how we wanted to improve our rehospitalizations. It made sense to us to utilize the blood pressures. We were able to, talking to our staff, helping them understand the importance of discharging our patients with blood pressures less than 140/90. Next slide, please. So the benefits of the program, like I said, gave us a starting point for our cardiac care. It provided us the tools and resources to drive both our staff and our leadership engagement. And it gave us the usable data that we needed to help drive our staff and provide the threshold of care for our patients. Our PI manager would frequently say, how are you measuring your outcomes? You can't have an effective program without good data to back it up. And so the Million Hearts Initiative and Milestone 5 is what really made sense to us. So that's the direction we headed. So we thought we were going to coast, that now that we'd made the decision to do this, that piece of cake, but the reality of it is that's when the real work really began. So the first step we did was to educate our staff, and so I started attending all of our staff meetings, both for our field staff that were in the medical teams and to our specialty teams. It was important for us to stress upon the staff the importance of discharging, paying attention to our patients' blood pressures and discharging them with a blood pressure less than 140/90. And if it was anything higher, was that really, were they really ready for us to discharge? So we talked with the staff about embracing the team approach. A lot of times, field staff get out there and think that they are out there by themselves. So reinforcing that they had, nursing behind them and therapy behind them and dietitian, social worker. And we also have a contract with our local pharmacy school, and students actually do a rotation. It's a 6-week rotation through our, and they meet with our patients at the bedside or in their home and do a total med review and make sure patients, are taking the medicines. If they're not taking them, why can't they? Can they, or is it an affordability issue? Is it, that they forget? So just trying to work with the patients on taking their medications and why they are or are not taking them. Front-loading our visits, incorporating teach-back with our staff, identifying patients' lifestyles and are they willing to make the appropriate changes or necessary changes that they need to be successful, and then ensuring that all patients have scheduled their follow-up doctor's appointments for when they are discharged from the hospital. Next slide. So we armed the staff with really just 3 basic questions to talk with their patients, especially when we talked about their lifestyle changes, is asking the patients what do they see as the main problem, what did they think they needed to do to resolve the problem, and why is it important to them? Because what we found was if it wasn't something they were willing to do, then it wasn't going to be successful. And then we pulled in the patients' families as well and finding out how do families learn best and how do patients learn best. Next slide. Pulling in the internal office staff was our next step after we provided all the education for the staff. Upper management and our leadership team were, they were on board from the beginning, which really made the success of this program very was very important to making it successful. When we, as Vanessa had talked to, the first 3 milestones were relatively easy, but it was when we got to milestone 4 that we pulled in our office coordinators to help with printing the patient's EMR, scanning them into the computer, and utilizing our IT department to help upload the information onto the disk that we, at that time, sent over to HHQI. Our PI team was involved from the beginning, and they were very instrumental in helping with our data collection and the documentation. And then the education team worked together to provide the education, pull the materials, put materials together for the staff and the patients. Okay. And like Vanessa, our milestone 4 was very intimidating. You have to enter and close 6 months of data, but for us, it was more like entering and closing a year's worth of data. We just weren't sure that we could really, did we want to go that extra step to pull the data on 30 patients, and were we were submitting it to people we weren't even familiar with at the time, and was this, did we really want to know our outcomes, or did we really want to know how we were doing? So we struggled with crossing over to that milestone 4. But with the help of Cindy and HHQI, they were very supportive and very instrumental in helping us take the, as you could say, the ball over the goal line. So once we found out that we had passed our milestone 4, then it was a matter of maintaining that same status for the next 3 months. Next slide. Which is, one back, which is what took us to the milestone 5. And that is along with the first milestone, which is, applying for it. Milestone 5 was relatively easy, at least for us, because our staff were already they were already on board with really watching our patients' blood pressures and identifying if they weren't ready for discharge, with, if their blood pressures were still running high, what else could we do prior to getting them discharged from our agency to help them, the patients themselves, maintain and manage that blood pressure better. And as Vanessa had alluded to, it was really empowering those patients and making them realize that they were in charge of managing their own care, and that how much better they would feel with being successful with that. And I think that is in part a lot of where our successes came from, was the staff really taking ownership and really working with their patients to make this happen. By the time we realized we had passed milestone 4, we were already 2 months into basically the maintenance of milestone 5. So it was just basically another month of submitting our data when we found out we were successful in milestone 5. So maintaining it and keeping it going is probably been our biggest challenge. So as you can see, go to the next slide with the rehospitalization rates. So as you can see, in 2013 and 2014, our rehospitalization was above the 20%, and then near 20%. And then in 2014, we had dropped to 15, just about 15%. 2016, 2017, we are starting to creep up just a little bit. And next slide. There's reasons for that, but what we learned first and foremost is that you want to ensure that the measures that you're focusing on will align with your agency's needs and your core competencies. You need to involve your staff in the study, explain their role and how they can make a difference, and really get their buy-in. You can't be afraid of their results or your results. You have to be willing to accept where your weaknesses are and where you need to make your improvements. Use your information you receive to further improve your patient care, your documentation, and your practices. And as I said, communicate with your HHQ coordinators because they're very knowledgeable, have been tremendously accessible and supportive. And I think, is there one more? So back to talking about, you know, where we failed with our or where we didn't fail. Our rehospitalization over the 2 years has crept up, and then part of that is taking our eye off the ball. You just have to maintain focus and have to continue to want to make those improvements and not change EMRs in the midstream, because that really has probably been one of our biggest impacts is staff having to learn a whole new system and not paying as close attention to the small details when it comes to patient care. So thank you guys very much, and I think that's all I have. We'll pass this ball to Cindy.
Thank you, Nancy.
Misty's already got it. Okay, thank you guys very much.
Not a problem. Thank you for presenting this. We appreciate the content. The roadmap to cardiovascular success that's been discussed here today, I just wanted to go over it very briefly for those of you that are new to this process, because there are some of you that are. And what they're talking about with the cardio milestones is just a unique way that we develop to walk someone through the cardiovascular improvement. So we're looking at milestone 1 is just simply joining the CardioLAN. Anyone that's joined the joined the CardioLAN, you've already reached milestone 1. If you're wondering where your agency is, when you go on the HHQI website and you hover over the cardiovascular tab on the blue toolbar and click on milestones, at the bottom of that page you'll see an interactive map. You can click on that map of your state and find out where everybody is, or if you want to subset by those who have achieved milestone 5 and 4 and go that direction, you can filter it however you like. Milestone 2, just like Vanessa said, is very simple. You're just downloading a couple cardiovascular BPIPs. The idea is to gain the knowledge to make the improvements and start your process of gaining access to the data. Milestone 3, just simply going in and closing 1 month of registry data and just download the report. Doesn't matter how many patients, it doesn't matter which ABCS. Milestone 4, that is the more challenging one. It's just the way Vanessa and Nancy described it. It is challenging because you are submitting data or your charts so that we can do a blind abstraction. The idea behind that was simply, anytime you do a chart audit in your agency, you probably have 2 clinicians or 2 nurses abstracting the same amount of information, and you do a comparison, such as an iterator. Well, we wanted to remove that level of difficulty or challenge to you and provide it by us. And so all we're doing is we abstract it blindly, the same as you do from the patient's record, and then we just do a crude agreement. The idea behind that measure is that before you use this data to create quality improvement, you want to know that it's accurate. And so that's just checking for accuracy so that you know what you're working with prior to developing a PIP or a QAPI around it. And milestone 5, which 2 of our presenters today are milestone 5 achievers. We are thrilled that they shared their information today because this is the pinnacle of the milestones, and that is showing sustainment. We all know that COP, it is data-driven, demonstrate sustainment. And so that's what we wanted to help with this. Being that there's no questions and we're at the top of the hour, we're going to go ahead and close. I would just say that as you have questions and you're working through this, please don't hesitate to contact us at HHQI. We'll be happy to work with you, help you, explain anything that we can, or do whatever we can to support you during this improvement challenge. So we'd like to thank all of you for joining us today, and we hope that you'll be able to implement a few of these processes that we've heard about today and the strategies and into your own practices and your QI. One thing I want to note that during these times of questionable weather, please be safe in traveling between your patients' homes, and also please, for those of us who are no longer able to work with patients directly, please enjoy your time with them. Remember that you may be the only light in their holiday season. And from all of us at HHQI to all of you, we hope you have a wonderful and peaceful holiday season. Have a great day, everyone. Bye-bye.